graduating with her DO degree. Prior to entering medical school, she worked for several years as a corporate wellness exercise physiologist with such organizations as KeyBank, Moen, and Ohio University, and others. After graduating from Ohio University College of Osteopathic Medicine, she completed a rotating internship in family medicine at Suncoast Osteopathic Hospital, followed by her residency. Dr. Ohms is board certified as an athletic trainer, boarded by the National Board of Physicians and Surgeons in Osteopathic Family Medicine. She has professor of health. She was a professor of health science at Ohio University, is now adjunct faculty at the University of Tampa in Tampa, Florida. She is a frequently invited guest speaker, both local and at the state level. She is a recipient of multiple recognitions from professional and community groups. Please welcome Dr. Ohms.
Hi there. How is everybody today? Am I too loud or you hear me just fine? Pretty good? Okay. All right. When I first decided to do this topic, it's actually been a passion of mine for the last 3 or 4 years since COVID started. But I didn't realize, once you start getting into it and it sends you down a bunch of rabbit holes, we're basically going into the physiology of every system in the body. So I'm going to kind of go through some things a little bit quickly. If anybody needs extra references, if you want to take pictures of the slides, and then obviously I guess we all get a repeat to look at it for a month afterwards. But if you have any questions at all, just let me know, okay? So as Dr. Ottaviani said, my background has been in a lot of lifestyle medicine, nutrition types of things, which is basically what COVID is. It's bringing us back to the basics for how to heal people or prevent it from happening in the first place. My master's in exercise physiology, I was very happy doing that. I learned a lot about nutrition, about lifestyle, and about reactive oxygen species and free radicals. And that is much of what the damage of COVID is. And then more learning accelerated through my doctorate in osteopathic medicine. And obviously anybody who teaches knows that you learn a lot as you start teaching. I guess it was 2014, 15, I started doing a fellowship, working on my fellowship towards it in functional medicine. It's a lot of people kind of don't know what functional medicine is. Basically what it is just bringing back those osteopathic principles, right? So nutrition, healing from the inside out, looking at the body as a whole and trying to figure out what's going on. And I've had a lot of aha moments through my training, things that I wasn't able to understand or didn't understand at the time, even from medical school. Once I started some of those trainings, I would think about certain patients that I didn't know what to do with. And I would highly recommend any of you to take a course or go to a functional medicine conference or something, because it really opens your eyes on a lot of different things. My office is in St. Petersburg, and I've been there for almost 8 years now. And again, my email's here. If any of you have any questions, just let me know. So my areas of interest as a functional medicine, osteopathic medicine physician. Obviously, COVID, long COVID, prevention of COVID for sure. I do a lot of functional bioidentical hormones. I do a lot of autoimmune types of things, which still takes us back to the basics in physiology as far as gut barrier dysfunction and what to do with that patient who comes in and says, I went to see rheumatology and I have a positive ANA, but they told me I wasn't sick enough yet to come back later. Well, my job as a functional practitioner is to try to prevent that progression from happening in the first place so it doesn't go into a full-blown autoimmune disease. I deal with a lot of GI disorders with that, as well as with dysbiosis, and obviously just trying to prevent aging and slow that trend as much as possible. So one of the first things that I do with my patients is I try to teach them a little bit about methylation and reactive oxygen species. I say, if you had no complaints whatsoever when you come in here, I would say, but you told me you wanted to live as long and healthy as possible. What I would say is, we need to make sure that you are methylating. And this correlates with long COVID in so many ways, because we have a double hit with COVID, right? We have the viral hit that is free radical damage. And then we have the immune system hit on top of that. So both of those things are very simply what we need to prevent and be proactive about with our patients. The other things that I do, I highly recommend looking into DutchTest.com. I do Complete Dutch, which does some hormone labs. So even if somebody isn't interested in doing bioidentical hormones, knowing where their hormone levels are is very important for their longevity. It's also very important for cancer risk. So we get to see how they're breaking down their estrogens and what pathways, because we know that breast cancer, prostate cancer, those types of cancers are very prevalent these days. And we can do some simple things nutritionally, lifestyle wise, and supplementally to kind of prevent those things from happening. I also do a cortisol test. And I think cortisol is one of the, at least one of the most important things that we need to look at as well with long COVID. What happens is, it's kind of what comes first, the chicken or the egg. Does the person have so much damage that to their mitochondria that they can't get the energy systems working? Or do they have so much chronic fatigue that comes from the cortisol system being depleted, or both? And which one came first? It really doesn't matter in my book. We treat both of them. And then the last page on the Dutch is what got me into looking at more parameters when people came in with COVID problems or vaccine problems. What this is an organic acid test. Has anybody ever used an organic acid test? Okay, a couple of you. So basically, an organic acid test is a way to look at whether or not somebody is actually absorbing certain nutrients. So we can check a B12 level, for instance, and in the blood, but we have no guarantee that it's getting absorbed. Now we can double check it a little bit with like a homocysteine or something like that. But what the Oates test or the organic acid test does is it says, okay, how much of all of these things do you have that are in that Krebs cycle pathway, or that pathway that helps reduce free radical damage in the body, okay? And I'm gonna explain this all a little bit more, so just bear with me. So the lab testing that I usually do is that Dutch panel. I make sure I check as many of the B vitamins through that as possible. I check the omega-3s, full thyroid panel. I used to be one of those physicians that rolled my eyes when people wanted their T3s checked, but you can tell some things about T3, about the person, by checking free T3s and reverse T3s and that sort of thing. It leads you to believe that there is a mitochondrial dysfunction. If the reverse T3, I use 20 as my parameter. If it's higher than 20, you know they have a nutritional depletion and a mitochondrial dysfunction, or at least you should suspect that, okay? The CMP and the CBC, obviously. I also look on the CBC, even if they don't have anemia, I look for them whether or not the MCV is low. So if they have thyroid dysfunction or they have a cortisol dysfunction, a lot of times a low iron is a portion of that, okay? So MCV being low, even if it's not creating an anemia, can be a sign. So all of these things we're looking at, just kind of minor nuances, and they can give you a way to go when the patient says, what's wrong with me? All of my labs are normal. Some of the autoimmune markers, I don't always check these on people, but if somebody did come in with COVID, if it is one of my autoimmune patients and they had COVID or they just had a vaccine, if they're having any symptoms whatsoever, especially shortness of breath, I do check those. I check a lot of the cardiolipin and the antiphospholipid types of labs with that. And then micronutrient testing. If we have the Dutch, we have the Bs, we have the omegas and the vitamin D through the regular blood labs. But if you really want a full panel to see whether or not the person is absorbing everything, a micronutrient test and a full oats test would be the way to go. So when the pandemic started, I think these were some of my questions and observations. You know, we're all sitting there saying, okay, why did this person get really sick and why did this person not, right? And much of what I came down to and why I showed you all of that, all of those slides before this is because it came down to my patients who were depleted. So anybody who came into me with any of these symptoms from COVID or COVID vaccine, I would check these and they were always low on the B vitamins. They weren't methylating well. They were depleted nutritionally in other ways. Their vitamin D was low. So it was one of those things that early on, I kind of caught on to it being a mitochondrial problem and the inability to clear some of this free radical damage, okay? Some of the increase in the dysautonomia symptoms, I was trying to figure that out as well. And that correlates with it too. And I believe you're gonna have a really good talk tomorrow, I think, on dysautonomia. There was definitely an increase in autoimmunity. So I had more people with positive ANAs. I had more of my Hashimoto's and my people who already had autoimmune dysfunction having problems with their antibody levels raising. And I'm of the belief you can use those levels as markers for how much inflammation is in the body and whether or not your treatment plan is really working. So I know a lot of people believe once you see them positive, you leave it alone, but they help you figure out whether or not you're making progress with the patient. Definitely an increase in hypercoagulability. Obviously, you can see that I'm not a sparse lab runner, right? I do a lot of workup on a lot of people because they come to me after they've probably come to a lot of other people who have not been able to figure things out. I check for D-dimers. If somebody had COVID and they have shortness of breath and there's no wheeze, there's no pneumonia, I check D-dimer because sometimes it is microclots in the lungs. And treating that portion of it helps them breathe. So, and that's one of the things that we didn't realize in the beginning. We thought it was all like an influenza where it was a pneumonia. But some of the inflammation these people have and what puts them in the hospital are, you know, microclots and thrombotic types of things. I also saw, sadly enough, and still do, increases in infertility. I try to ask and be curious as much as possible with our specialists, especially the OBGYNs and what they're seeing. And it's kind of one of those things that's known at this point. Okay, so this is really busy, a lot of word, everything that you guys probably already know. All of the different symptoms, pretty much any symptom a patient could have is a long COVID or a vax related type of symptom that you've probably heard from your patients. So I won't dwell on it too much. But, you know, the main thing is much of this can all be summed up in just a few things, okay? The mitochondrial dysfunction, and I'll go into that, as well as a gut barrier dysfunction. The gut-brain connection with your immune system can either make something hyperreactive or not reactive enough. And those are two of our main things that we're seeing with long COVID. So the other thing that I wanted to show you is with that busy slide and all of those symptoms, this is a slide as far as mitochondrial myopathies. So you can see just about every system in the body is affected, and it's almost overlapping exactly for what we had on the long COVID symptoms. Okay, so it gets you thinking, you know, if you have the cardiac symptoms, I added some of the cardiomyopathies, there are obviously other types of things. I had my first patient with an accelerated development of aortic aneurysm. She had had a CT calcium score done. Everything looked fine like 3 years prior. And for some reason or another, I can't remember what her cardiologist wanted to do. She did another one within 3 years. And they even checked back to make sure it wasn't missed on the first one, and it wasn't. So, you know, my level of suspicion or my threshold for being suspicious about things is much lower now from a cardiovascular standpoint. I've had several other patients with TIAs in their 40s. You know, there's just a lot of cardiovascular stuff that you would normally kind of say, it's probably not that, but we don't know what's coming and we don't know all that's developed and we're still learning about it. So level of threshold for me is a little bit lower than what it used to be in those matters. Infection. So if you have somebody who had chronic HSV, cold sores, genital herpes, or Epstein-Barr, or any of those other types of viruses the immune system usually keeps at bay, those all seem to come back. How many of you have noticed increase in strep along with COVID? Anybody? Okay, so, you know, these things we have to look at because we're dealing with something that we've never really seen before. So again, I keep saying get back to basics. The other day or yesterday, Dr. Hasty, when he gave his lecture, he was making a joke and said, nobody ever, knowing the Krebs cycle never saved anybody's life. And it was kind of funny because I would have never thought it would either, but knowing the fact that the Krebs cycle exists and what it does in the mitochondrial standpoint can save lives and can give people better quality of life. So back to the methylation. This is a busier slide of the methylation, but one of the things that I wanted to point out with it was everything that is going on. Okay, we've got brain and nerve damage, and that activates the brain's immune system. And that goes hand in hand with the immune system that's in our GI tract and our gut. So if we start out proactively with these people, they have less of this, okay? If they have more reserves to fight free radical damage, they have less damage and less chance of getting long COVID. So I'm gonna go brush through here a little bit more quickly. So let's go to one of the top things that I think tends to be the problem. So much of our detoxification, our lack of energy, with long COVID, our all of those types of things stems, much of the research now shows that it stems from mitochondrial dysfunction. So I'm not going to get into a lot of the anatomy, but obviously it regulates our metabolism, it gives us energy, it plays a big part with calcium, and that helps us with our steroids and our hormone synthesis. So that's where we get into the cortisol types of things, as well as our sex hormones. Our ability to adapt to stress and infection. Mitochondria are huge for that. And then one of the biggest things that I'm going to talk about today is the mitophagy and the apoptosis. So when a mitochondria, or when you go through some type of viral infection, basically what happens is your body gears up the mitochondria. They go to wherever they need to in the body. They increase in number, they increase in power and production. But when they're done with that, they're basically supposed to go through a programmed cell death. And what happens in COVID that's very unique is, or at least it's postulated at this point, is that they don't go through that autophagy or that apoptosis. They do not. So once they go through the cell death, then you're supposed to have new, more robust mitochondria forming. So the thought is, with the recent studies, is it's not happening with COVID. And if it's not happening, then you're functioning on low power, whether you've had COVID, the vaccine, when you've been exposed to the spike proteins, and when your body is reacting to them, you have less of the ability to go through that. So much of my treatment is trying to get people to go through that at this point. All right, so this is a slide. Elroy Vajdani and his father, Risto, are very big as far as their research in COVID. Now he puts it, he calls these buckets, okay? He puts all of the causes in the way of the interrelationships with long COVID into these 6 buckets. I kind of simplified it because a lot of these overlap so much. Mine still do. But if you just keep it simple as far as what you need to do to be proactive with the patient, it makes it much easier for you to handle them when you only have a few minutes in your office with them when they come in. So part of what he's saying is that there can be persistent viral remnants, and we're seeing more and more of that. So we have to remember that COVID can come back. Some of the medications, we get rebounds. There can be viral particles that are released weeks and maybe even months later. And it doesn't take a live virus necessarily, but it takes those particles to make the immune system continue to react. So if anybody had COVID and it seems like, okay, it's getting better, and then it's not, and then it's getting better, and then it's not. It's not like any other infection. And some of that is the release of those viral particles. The mitochondrial damage, which I'm going to get into in a little bit more detail, the disturbance of the gut microbiota. So that is that gut permeability issue, and I'm going to touch on that briefly as well. The viral superantigen. So again, immune system and what helps us stop the immune system from overreacting, we're going to touch on. Multi-tissue damage from autoimmunity, including in the brain. So things that we can look for to see if this is a portion of what's going on. And then reactivation of those latent viruses, as I had mentioned, the HSV and the Epstein-Barr. So my breakdown is mitochondria, the gut barrier, nutrition, and cortisol. And they do intersect, but I try and keep it very simple. What things do we need to check on this person? And then go from there. If they have a good gut barrier, they're less likely to reactivate some of these latent viruses. They're also less likely to have a hyper reactive immune system. All right, so this is a very busy slide as well, but it puts everything in place. We've heard a lot about ACE2 receptors. We've heard a lot about the free radical damage and how mitochondria are supposed to basically help us methylate and correct some of that free radical damage. So if you remember that slide that I showed you on the first one that I showed you on methylation, basically all it takes are your B vitamins, a couple of amino acids, to help you make glutathione, which is our main antioxidant. What do antioxidants do? They neutralize free radical damage. So making sure that system is running right. So a lot of times, like I said, there's a double hit with COVID. First of all, you're spending all of that antioxidant strength on fighting the virus, but then you have that secondary immune response that comes in, and that creates some free radical damage that needs to be methylated as well. So it's a huge double hit, which is why we have to have some reserves in place before the patient gets sick. This is, sorry about the blurriness, but this is showing one of the main substances that is important in the mitochondria. This is what is thought to be the problem with the apoptosis happening. Okay, so I'm going to go through this. This is a lot of physiology. If anybody would have told me 20 years ago I would be doing this much physiology, I would have laughed in their face. So the cardiolipin, okay, it's this thing that helps carry something called cytochrome C in the electron transport chain. Okay, this is part of what revs up the engines in the mitochondria. So I sometimes use the analogy trying to explain it to people and have them picture it as the car. Okay, you have a car and you have a catalytic converter and you have fuel that you need and you have oil. Okay, so the mitochondria is very similar that way. Okay, but this is part of the energy system. So if somebody has a viral infection, basically what's supposed to happen, or something that stresses the body out where the mitochondria are overworking, okay? At some point when that is done, the mitochondria are supposed to signal for that programmed cell death, for that apoptosis. And part of that signaling is they release the cytochrome C, and then when that happens, it carries the, it releases it into the cytoplasm. And then the mitochondria is seen as, to the immune system, is seen as kind of reaching out and saying, okay, I'm ready to go now. Let somebody else have their turn, and that's what's supposed to happen. Once that cardiolipin goes to the outside membrane of the mitochondria, that's supposed to be the signal to say, okay, now, phagocytes or whatever, again, I'm taking you way back to physiology, go ahead and engulf, and then that starts the process of making a new, more robust mitochondria. In COVID, that isn't happening. So a lot of the newer studies are showing that that process isn't happening. But what is happening is that cardiolipin is sitting on the surface of the mitochondria. So the cardiolipin, if anybody is doing rheumatology or whatever, that is a prothrombotic type of signal, okay? And we have that in platelets, we have it in all kinds of places. So this is thought to be part of what happens in the cardiovascular system to increase clotting, okay? Because we're not clearing that off. That should be done by the time the cell goes through, or the mitochondria goes through apoptosis, and it's sticking around, okay? So this, it persists on the outer surface, and then that leaves us with this mitochondrial damage. We have DNA that's released from the mitochondria at that point because it's not being cleared, which is also not supposed to happen. So that also increases the inflammation and the free radical damage. And then the mitochondria are rusty and worn out because they're not replaced with new, more robust ones. And then, like I said, the cardiolipin on the surface is clot inducing, and it creates a situation where we have increased antibodies to cardiolipin. So much of what the newer thought is testing for anti-cardiolipin antibodies, antiphospholipid antibodies. There's a whole slew of them, ANAs, all of the types of things that are autoimmune markers are a good way to gauge whether or not something could be long COVID or it could be.
I could not leave the house
it is
early
persistently
enough this
seen
morning.
in patients with long COVID if you test it. Okay. All right, and just some studies. Again, I'll have a resource list of all of the studies that I was wanting to put up here. I just kind of want to move through it to make sure I have enough time. Okay, so this is like your battery is dying in your car. The car is all rusted out, right? And you're out of gas and there's no oil, okay? So we need to fix this, and some ways that we're going to do that. And also detoxification isn't necessarily happening for that person either, because the mitochondria help us very much with that. So we're tired and we can't correct the damage that's in the body at this point. And that is essentially long COVID. All right, so compounding factors with this. I just want to touch briefly on it because I'm going to go back to kind of the emphasis of the mitochondria, but this is a big portion of long COVID as well. When we have gut barrier dysfunction, we term it leaky gut sometimes, and I get some people frustrated with that, but this is the crux of where a lot of autoimmune disease comes from. We have 75% of our immune cells circulating in the small intestine at any given time. And if we have a gut barrier disruption,
Good morning.
We have problems with that immune communication. Basically, everything is supposed to go through the border, through the cells, all of our nutrition. And for one thing, that's a good way for preservatives, colorings, dyes, artificial sweeteners, GMOs, things that don't belong. As we digest our food in our stomach, we are breaking it down, and then it should be accepted into those cells. If we have a barrier disruption, then it's a free-for-all. Everything goes across the barrier, and that creates a lot of immune dysfunction. That's how I treat, or what I see when I treat a lot of immune disease. We know COVID, through studies that look at zonulin and APS and a couple of other things. Zonulin is kind of like the staples of those cells, binding those cells together. We know that people have an increased output of zonulin when they have a COVID infection. So COVID really disrupts the GI tract, and that starts a lot of the autoimmune sequela. So we know people get diarrhea, they get some bowel movement problems and that sort of thing, but there's much more going on, especially if it's hitting the GI tract harder than it's hitting other portions of the body. And the autoimmune sequela after that needs to be thought about. Okay, so then we have that cytokine storm that can happen. So if somebody has long COVID, they have barrier dysfunction already, especially, or they have a severe barrier dysfunction coming from the COVID, then that leads to that whole antigenic response that basically causes a lot of the cytokines to be released and makes the situation even worse. And one thing to remember, and I'm sure you've all seen it, some people really surprise you with COVID. It's not always the first 10 to 14 days. Sometimes it's a month and a half later. And some of that is due to this long-term immune system damage. It doesn't always happen all at once. So then to go along with some of the gut dysfunction, that dysbiosis, if you have an overgrowth of bad bacteria, you have fungal overgrowth, a lot of times those kind of override the normal function. So making sure the person, either through fermented foods or bone broth or what have you, or through supplemental probiotics, that they have that covered. The more you cover it with good probiotics and good little guys, the less likely you're going to have problems with the bad ones. But this is also something that we see in long COVID. After the initial sequela, we usually see, an overgrowth of yeast. If somebody's having a lot of GI issues or malabsorption issues and that sort of thing, look for yeast. Okay, so now when we look at our workup, much of it is overlapping what I showed you initially of what I do with a lot of my patients, but we're going to add a few things to it. The first thing that we're going to look at is those autoimmune markers. For sure, they're going to be kind of, on your index of suspicion. If somebody isn't eating, if they have, a sense of smell or taste distorted, you're going to deal with a lot of nutritional issues with these patients. These are some of the hardest people who cannot sleep after COVID and people who cannot eat after COVID. Those are the hardest uphill battles. And, those two things, sleep helps us with our cortisol function. It's number one. It's most important for healing a chronic fatigue and a cortisol dysfunction. The nutrients help everything, right? So getting good nutrition in is very, very important. And then hormone balancing, I would put at the bottom of all of these, but if somebody is depleted already, if you have an elderly person and they have sarcopenia, they're already wasting. We need, anabolism. We don't need catabolism during all of this. So then what I had said before about the cardiolipin, there are antibodies that you can check for. So an anti-cardiolipin antibody, your general antiphospholipid panel, Quest, LabCorp, they all run these. There's a company called Avise. Has anybody used Avise before? Avise gives you everything autoimmune. It's such a neat panel, and their experts help you out quite a bit if you're new to it. But this is where I started looking. And this is where I found a lot of the activation of these things throughout COVID. It also helped me figure out how long to treat them with baby aspirin if it was needed. I wanted to make sure I was going to catch some, prevent some clots from happening in some of the severe cases. The mitochondrial antibodies, so there's an anti-M2, there's actually a whole bunch of them. Mitochondrial free DNA testing, which I don't know a whole lot about, and I don't know how readily available it is, but it was one of the things I came across in my research. From a neurologic standpoint, if they have dysautonomia or they have those types of symptoms, doing orthostatic, vitals, postural testing and tilt table testing. There are also several panels to look for autoimmune markers for like brain antibodies. That myelin basic protein is one of them that gets seen a lot, and that alludes to a brain and gut barrier dysfunction. The persistence of COVID-19. So I was using Boston Heart for this for a long time. I do not use some of the major labs for this. They basically skewed the results. And I don't know if they're still doing it. I just stopped in the beginning. When I was trying to look and see how long people's antibodies were lasting, basically some of these labs were setting a different level of threshold. So somebody who just had COVID would show up negative. So I just started double checking them with other labs. And the person, I had 12 people, granted small population for a study, but we tested all of us and they were completely different. And so I got both lab directors on the phone and I said, what gives? I said, I'm trying to figure out whether or not people need to, re-up their vaccines or if they're good to go or what. And it was basically one of the major labs said that they were skewing their own results and basically bell curving them. So, you have to know that you can trust your labs when you're looking at these results and relying on them. The other thing is immune status. So Cyrex is a good specialty lab that looks at CD4 cells, that looks at all of your T helper cells. They have really nice panels if you want to get into the immunology portion of it. I don't tend to do that. I tend to focus on the mitochondrial and the cortisol and the nutrition, and my patients tend to get better. A lot of times I leave that decision up to them though. Some people want all of the data. They want to know everything, and I'll run whatever they want, but I try and do it as simply and cost effectively as possible and get them better as quickly as I possibly can. The D-dimer, like I said, I do run on patients who have severe symptoms, and they come back positive. I had a patient who she was sick. I don't know for sure that it was COVID. She never tested, but she ended up having chest pain and shortness of breath more than she usually did going to altitude. She was in Canada and they were hiking. And when she came back, we ran some of these labs and she had a persistent D-dimer. And I would probably bet money that that was COVID and that the instigated some of her symptoms. Cardiovascular testing if warranted. Again, I want everyone to think about being curious. I mean, I would love to sit in a room with all the different specialists of all the different systems that affect COVID, because I know all of us don't get a chance to talk like that. And it's just interesting. And it's the oncologists, the hematologists, and the cardiologists, and the OBGYNs that are seeing huge differences and shifts in the types of things that they are the symptoms that they're seeing in patients, and kind of the sequela that's coming from that. All right, so an ounce of prevention is worth a pound of cure. So before I go into a lot of the treatment plan for long COVID, I'm telling you, it's very, very important to be proactive and prevent these things from happening. If you have your patients, make sure that they are nutritionally supported so that they have those reserves that they can make it through an infection. You're going to have less people have bad outcomes and less people having long COVID. So check the B's. Vitamin D doesn't just need to be 30. All the studies, I mean, this is probably the only thing everybody agreed on during COVID, right? Vitamin D needs to be somewhere between 50 and 75. I don't ever dose more than 10,000 IUs, but if somebody has COVID, no matter where their level is, I dose at 10,000 IUs for a couple of weeks. I've never, ever, knock on wood, had anybody with any kind of vitamin D toxicity, and they never get above 100. And 100 is not going to create a toxicity, okay? I would make sure that they're not overlapping things though. I get a lot of overlapping in zinc, and if they're on it for a long period of time, zinc can cause a copper disruption, which isn't good either. So you need to make sure they're not overlapping a bunch if they like a lot of the supplements and that sort of thing. I guess I should probably talk about that. So I try and get as much through nutrition as possible, but let's face it, our food is depleted. I mean, if I have somebody eating a whole food diet, a lot of times their Bs are fine. If they're vegetarian or mostly plant-based, I don't usually get the Bs where they need to be. If they drink at all, they don't get the Bs where they need to be. So I'm always checking these types of things. I hardly ever get vitamin D where it needs to be. If you have somebody who has more melanin in their skin, you're hardly ever going to, I really honestly, very surprised how in Florida we're still having vitamin D problems. If you do have them supplementing at higher than a 10,000 or where they're at 10,000 IUs and they're not getting their numbers to 50, suspect a magnesium problem. Okay, so magnesium helps vitamin D become active. So there's a lot of little minor nuances with some of the nutrients, but we're just not getting a lot of them in our foods these days. Omega-3s, if you have any kind of flaxseed or chia seed, you'd have to eat your weight in it to get your omega-3s where they need to be. So you want good sources of fish. Other than that, I would say a physician grade fish oil where they've filtered out all of the junk. The homocysteine testing is a good way of at least getting an idea of where their glutathione is. Again, that's the main antioxidant that we use as a marker of that reserve. Okay, so if their B vitamins are good and their glutathione is low, that's either going to be some of the amino acids are missing, which is usually not the case, or they're just burning through the glutathione because they have so much free radical damage. Then we look at their hormones and their gut barrier dysfunction and inflammation. So if you have patients where you can, talk on these points, they say, how can I prevent COVID? I hear there's a whole bunch of cases coming up. These are the things that you just want to start, pick one. I know it takes time and many of your practices aren't like mine where you can spend more time with the patients each visit, but take the time to just, set a handout up for them and say, okay, these are the things that I think that we need to focus on, and check some of these things in their labs. That vitamin D is so important. It helps boost the immune system to a certain point and keep it in the sweet spot, but doesn't allow it to overreact. So it helps us when our immune system is low, and it helps us if we have a hyperreactive immune system, it calms it down. It's very, very important. Okay, so then if somebody does get COVID and say we haven't done a lot of those things, if they do, I try and make sure that they do have those B vitamins so that they can methylate well. I'm going to give you a couple of my favorite types of things that I just add to it. So, my dad got COVID with the first batch, the first strain, and I was so concerned. He's diabetic, he's overweight, he's nutritionally depleted. I threw the kitchen sink at him and he did just fine. He wasn't thrilled to go through it, but he did just fine. So NAC, N-acetylcysteine, is a precursor. It's one of those amino acids. It's a precursor to glutathione. So adding the B vitamins with N-acetylcysteine is how we can make glutathione. The vitamin D, like I said, I go to 10,000 IUs, and then a probiotic. I don't always use a baby aspirin, but if somebody has comorbidities or increased, risk factors, then I definitely do. And I don't usually stop it before a month. If their symptoms can be gone, and some of the sequelae of the immune system can still happen. I mean, we can have blood clots up to 6 months after COVID or a vaccine related problem. One of the most important things, and why it's in red, is, pulse ox. You can get one on Amazon the same day for $15. And this is very important. I want to know, is some of the shortness of breath symptoms creeping up on my patients? Because again, that can happen anywhere within the first several weeks, right? So they don't notice it sometimes. Show them how to use the pulse ox so they're not calling you every 5 minutes saying it's 85 and you're freaking out. Have them keep it on the finger several times a day, move around, see how they're oxygenating. But I usually tell them, call me if it's below 95. And I tell them that doesn't mean I'm going to send you to the ER by any stretch of the imagination. But if your normal pulse ox is a 98 to 100, I want to make sure that I know at 95, now I need to start putting some other things in. So steroids, breathing treatments, figuring out what else is going on with the person and watching them a little bit more carefully. But, people have the smart watches, they have the Aura rings. There's so many easy ways that they can watch this. They can even watch for a lot of the AFib that happens in the arrhythmias. So just use those tools, and it's really helped my patients out quite a bit and helped us have that communication. So they're not too far gone and where they end up hospitalized. Okay, this is one of my favorites. So out of all of those, vitamin C, your zinc, your quercetin, a little bit of vitamin D, and the N-acetylcysteine, it hits 5 of those things. So if somebody does have COVID, the orthoimmune is from Orthomolecular. All physicians get it at a wholesale price. You can give it to your patients however you want to, or recommend it. You can sign up for a full scripts account where they can order it online. But I usually use 4 of these a day, and it cuts down on the rest of, I have a zinc pill, I have a vitamin C pill, I have this and that. It cuts down on a lot of what they have to take. It's very easy. It's kind of a one product type of thing. The next thing, so when we get into the mitochondrial dysfunction and how to treat that, Research Nutritionals is a company that I just found about I guess closer to a year now. It's what it says. They are heavy on their research, and it's good research. So ATP 360 gives you everything other than the B vitamins. It basically gives you the carburetor, the catalytic converter, the engine, everything that you need to run the mitochondria. So we're looking at ALA, PQQ, the N-acetylcysteine. It's giving you all of the different things that run the energy system if the mitochondria is rusty, and helps it get to the point where it can go through that apoptosis and the autophagy. And then if they're just really depleted, glutathione. So I've not ever been a fan of oral glutathione or sublingual glutathione, because I just felt like if it's not given IV, it has an extra electron, it's reactive. So how is it going to get to where you need it to get? I'm sure it's going to help something, but we want it to go where we need it to go. Well, Research Nutritionals has a product called Trifortify that is sublingual glutathione that has been proven to increase intracellular methylation, basically. So their website has all of their research papers, all of their information, very good products to help people out. So I don't use this in everybody, but if somebody is super depleted and they're having a lot of symptoms, they're having a lot of chronic fatigue, it's almost instantaneous what it does for people. It really makes both products make a big difference. All right, so then one of the things that I wanted to bring up about long COVID treatment is the cough. It seems so simple. We treat cough all the time, right? But people get worn out. And are you guys seeing what I'm seeing, especially with this last strain, where it's lasting like weeks and weeks if they're not getting treatment, right? So, and it's just, usually dry, tickly cough, but it is wearing them out. So as much as you can, try to, get insurance to authorize some type of inhaled steroid and that sort of thing, and give them what they need to get the cough gone. The more they hack away, the more damage they do to their bronchioles and their respiratory system, the longer the cough is going to last. Of course, we want them to cough everything up if they have, pneumonia or secondary pneumonia, especially. But that dry, hacky one, we have to be somewhat aggressive on, because this is really wearing people out. Energy, and I put neuro and cardio to save time with this. So basically your B vitamin reserve, like I said, in order to methylate and correct free radical damage, you have to methylate well. So we need B vitamins, we need that cysteine, which is in that N-acetylcysteine, to help you make your own glutathione. So it's sort of like, are you going to go to the grocery store to buy the ingredients to bake a cake, or are you gonna just buy the cake? Okay. We're trying to get the ingredients going so that the mitochondria can get up and running again, and we have more energy, more detoxification, and all of those things that the mitochondria do. The methylene blue I have not used. Okay. This is something that seems to be a big game changer. And when I looked into it, you have to get it from compounding pharmacies. I guess everybody's kind of sold out. So I kind of went down a rabbit hole with this whole lecture. I had heard about it before and just hadn't had the chance or the need to. It's an expensive type of treatment, but I didn't have the need to do it. But there are some really, really good papers on it and some really good results. I mean, everybody is speaking on it. So if you get a chance to look into it, I would highly recommend that. NMN and NAD. So we have lots of ways of getting that. Oral is a little bit of a milder boost than doing IVs of it, but there are several clinics that do it. RG3 is something that could potentially help, especially with the loss of sense of smell. It's peptide, it's intranasal. It's meant to help us with cognition and attention span and recall. I've heard very good things about it for that. I've used it on a few patients with mixed results, but it's something that I wanted to mention because I haven't used it for the loss of taste and smell. Barrier dysfunction, probiotics. If you're not sure, there's all different kinds of courses that you can take that kind of teach you how much CFU, what types of prebiotic you want in them and that sort of thing, because not everybody reacts the same. A really good one that I use is orthomolecular orthobiotic. It's a middle of the road, 20 billion CFU. So if you have any questions about that, just let me know. And then for the autophagy and the recycling. So how do we get that rusty old mitochondria to change over, right? Exercise, not heavy CrossFit Orange Theory exercise, but zone 2 mild exercise. I always tell the patients, if you feel like you want to curl up in a ball and it takes you 2 days to recover, it was too much. But gentle walking, stretching, getting some of the things moving and getting the body to kind of wake up again really helps out. Intermittent fasting helps out. Metformin is thought to be one of the things that can help, and there are some studies as far as that's concerned. Berberine, all of your oxygen, kind of the pressurized oxygen chambers, the HBOT, the H2O2 water, helping out with giving you more ability to fight free radical damage. Ozone and red light work very similarly and decrease inflammation as well. So then the anticoagulation and the autoimmune issues. So your vitamin D, I have a star beside phosphatidylcholine because you have to be careful with a few of these things. It's sort of like when somebody says, okay, it's January 1st and I'm going to do a detox program. If you're really sick because you partied like a rock star over the holidays and everything, that person's going to be really sick when they first start that program. You have to take it in steps. And with phosphatidylcholine, it's one of the things that you probably don't want to start until you know that the gut barrier is good and some of the inflammation is gone. Some of the peptides. So the SS31 is coming up for, I forget what drug company is working on the research for the use, the indication of it, but it's supposed to help us with this apoptosis and this autophagy and recycling and cognition. Nattokinase and baby aspirin both thin the blood, as does omega-3s. And then that intestinal and gut support can help us out. All right, and then if we have problems with some of the viruses, so the antiviral treatments, I'm not going to go through all of those. Those are natural treatments. We obviously can use some of the, prescription antivirals. Some of the repurposed drugs do help in this case. The antibacterial fungal secondary overgrowth, again, there's some of the supplements, but I'm not going to go through all of that. And then for the anosmia, and the foul smell, I had that for about 3 weeks and that was awful. Everything smelled like cigarettes, like an ashtray. So there's a couple of things there. I came down one rabbit hole when I was preparing for this with Absent, which is a company that's kind of gives you a package of smell therapy types of things. But I tell people just to buy a package of essential oils and just start sniffing away, because that's one of the main ways of getting that back. And then your good brain types of things, alpha lipoic acid, omega-3s help out. All of the neurodegenerative or neuroregenerative treatment, as well as the mitochondrial treatment, usually helps speed that up. OMT, acupuncture, gentle chiropractic, and somebody who has, fellowship trained neurochiropractic. All of these things can help with some of the dysautonomia, with the sympathetic charge that's happening and the regenerating of the adrenals. The cortisol support, obviously, is kind of overlapping everything else that we were talking about. And then any kind of specialist referrals if somebody has anything going on from a neurocardio or rheumatologic standpoint. Okay, so the uphill battle is getting the nutrition in. Our food is depleted. And as Hippocrates said, let food be thy medicine and medicine be thy food. So what do we know about food? This is the hardest part. Somebody says, can you give me a diet, right? You've got 10, 15 minutes with a patient and you don't know how they're eating, what they're eating, how many calories. This is so hard. So a lot of times when I don't have time to go through all of this, what I try and do is say, okay, how about I'll give you a prepped food list. So if you tell me that you don't like cooking or none of your family eats the same things and all they want is garbage and they're not going to change, then there are healthy alternatives. There's a ton. So I make these lists up. I make different goals for them, try a new healthy recipe once a week so they can bring some new foods in. I give them ideas if they're ordering from Uber Eats, what can you order instead? And then I have a lot of people on board who I've kind of vetted who are nutritionists or dietitians, or they can help them shop and show them what to buy and how to look for ingredients on foods. But these are things that you can refer out and still help your patients, because nutrition ultimately is going to prevent the long COVID from happening in most cases, as much as you possibly can. The overlapping themes are pretty much all of our nutrients. So if we can get it through food, great. If we can't, supplement. And of course, I don't have enough time. I knew I wouldn't. I'm going to stop right there and take some questions. Well, I want to say one thing. So one of the main things, I'm going to skip through some of this. I'm going to go back. So one of the main things that I wanted to touch on real quick, questions that I have right now. All of this research is emerging. We are in the state of doing more boosters. And I firmly believe, I'm not an anti-vaxxer by any stretch of the imagination, but from what we know on the cardiolipin and the mitochondria, the more hits and the higher viral load or the higher exposure to spike protein, the more damage that somebody has and the more rusty cars or the more rusty mitochondria that they have. So in my mind, it just makes sense. At some point, do we make sure that we need these? Do we make sure that we have the right ones? And that was one of the things I wanted to show you. Was I was going to show you a link to a video that talked about there being DNA material possibly in the mRNA shots. And they found several geneticists have come out and they've found them. And the video was gone. And this was testimony at a South Carolina court Okay. So it was, public record and it's gone. And you can find it on Rumble and things like that. And part of my disclosure to you is I am not affiliated with any political party. I could care less. I don't want politics in any of this. And I think that has hindered us as physicians. So I'm going to show you my wish list. So my wish list is we as physicians use our scientific brains to treat our patients, but never disconnect our hearts. We get back to the basics of nutritional and good lifestyle medicine to heal and prevent. And we don't let television, politics, or money enter into our clinical judgment. And we are not arrogant enough to think that we learned everything we needed to know in medical school and residency. And I would add one more thing, really look at your research. We all were trained over and over again how to read scientific papers. I had an excerpt on here, but more and more you'll see a title that says, we're seeing this happen, but in this case, but there was hardly any problem with it, or, obviously I'm paraphrasing, but then when you read the article, that's not what it says. And this can go, again, I'm not trying to be right side, left side, all across the board. We need to really urge our powers that be to help us practice good medicine and to have actual research guide that medicine. And if that research is skewed, then what do we have, right? All right, any questions? Sorry to get on my soapbox there, but I had to get it in.
We have one question from online, and that is, would you comment on vaccines to prevent serious disease, hospitalization, and death? Do you feel that's an area you're comfortable with?
Well, in the right patient. The question is, who's the right patient right now? And, the information about the mRNA or the DNA particles in the mRNA shots came out right about the time they started promoting the boosters again. Okay, that should have been something that got halted. And we have scientists who are saying that they're not seeing it cause a problem. But, look at the link I gave you, and it's Dr. Buchschelt, I think his name is, and he's a geneticist in South Carolina. And he's saying, I don't know if it's going to be a problem, but it's easy enough to see if it is. And I want to see before I tell somebody to have a shot, especially an mRNA shot. I want to see whether or not there's something that's going to create more harm than protect them. I will say I'm not huge on mass vaccinating kids. There's been so much cardiovascular, sudden death, all of those types of things. My son is 15 years old, so this is a subject that I have delved into greatly. And I'll stick my neck out there a little bit and say most kids do not need to be vaccinated. Not all. I'll never say all, but most kids have a strong enough immune system where it's going to cause more harm than good.
Hi, thank you for that. I have two questions. One, have there been randomized controlled trials demonstrating benefit of the vitamins and supplements either to prevent or treat COVID or long COVID?
Absolutely. Absolutely.
Can you cite some of those?
Yeah, I can. What's the best way for me to send? Absolutely. The only problem is most of them are small, population because there's no money in it, right? But that's where I like the companies that we have. Any functional medicine organization that's worth its weight always has those types of studies to back everything up. And I will tell you that it is catching on in traditional medicine as well. I just had a patient who was hospitalized and it wasn't COVID, they didn't think, but she tested negative. But they started her on antioxidant therapy. And, this is really a game changer. And it has started during COVID that, these high dose vitamin C in the high risk patients, they're really helping. Assessing their vitamin D level is really helping. And there is proof for that.
C, D, and zinc, yes.
Absolutely. What other ones do you have questions on?
I think we've looked at using high dose vitamins in the general population. And when they did larger studies, there was no benefit as far as longevity or illness was concerned.
Every time I've seen a study like that, they just told them to take a general vitamin.
Well, usually the comments are, if you want to take it, it's not going to hurt you, but we're not going to tell you it's going to help.
Right. But it's what you take, okay? For instance, two main things that I look for in a multivitamin, and I know I have to go, but two main things that I look for is it a methylated folate? 80% of the Caucasian population especially have at least one knockout of the MTHFR gene. And I'm sorry, I can't go into that. The next thing I look at, so not folic acid. Lots of people can't convert folic acid into their active methylated folate to get into that methylation cycle. The other thing I look for is B6 is paradoxal 5-phosphate. They use paradoxal HCl instead. It's a cheaper version and a lot of people can't convert that one either. So it has to be a good one. Those are the studies you want to see, is if the patient, is taking a good vitamin that is third-party tested, so everything that's supposed to be in it is in it, and there's nothing additive that's not, not supposed to be in it. Those are where we see the results. Okay. All right. Any questions? I'll step down. So the next. Thank you.
Thank you, Dr. Ohms.